Okay, good. Welcome everybody to the afternoon session. My name is Christoph Lees. I'm a consultant in fetal medicine in Cambridge. So this afternoon we're going to start off with thoracic abnormalities. And when I find the laser print... Yeah, there we are. Okay, good. And your first question is, was this Boris or me at medical school? Don't worry, don't use your audience response system. So, thoracic abnormalities. You've heard a lot about skeletal dysplasias, so I'm not going to discuss skeletal dysplasias manifesting as thoracic problems. Short thorax, narrow thorax, long thorax with protuberant abdomen. I'm going to be really talking about intrinsic congenital thoracic lung abnormalities. And of course, Rabbi Chowie and colleagues will be talking about the heart tomorrow, so I'm also not going to discuss heart problems. So, a few refresher questions before we start. Congenital diaphragmatic hernia. Have your response handsets, please, to hand. Right is more common than left-sided. Maternal age is a factor in its incidence. Missed antenatal diagnosis is associated with good outcome. Pleural effusion is common. So please do start to vote now. You've got another 5 or 10 seconds before we stop the responses. Okay, this is interesting. This is very interesting. We'll come back to this at the end. Of course, as a speaker, it's very difficult to work out how to word these questions so that you're sort of guided to the right answer. We will discuss that at the end. Okay, let's see what happens with the next question. Extralobar bronchopulmonary sequestration, ELPS. High output cardiac failure is more common than in CCAM. It's more likely to be associated with aneuploidy than congenital cystic anenomatoid malformation, CCAM. It's frequently treated with aspiration or shunting. And it's easily imaged with postnatal X-ray. So one of those responses is right. Please vote now. Okay, just the last 5 seconds of voting. Please cast your vote. Right, okay, interesting. Right, we will be able to go through those at the end. Okay, right, now into my talk proper. So, normal sonography of the fetal chest. You don't need reminding of this. The fetal heart area, roughly 30% of the thoracic area. And, of course, the thorax is an extremely vascular part of the chest. So it's not just a question of B-mode imaging here. It's a question of Doppler imaging using color Doppler as well. So classically here you see the baby's heart, which we'll learn a lot about at a later point. But here we can see the pulmonary vessels just coming into the baby's heart. So the point we're making here is that many of these diagnoses are not simply B-mode diagnoses, they're also color Doppler diagnosis. You don't need to get waveforms, you don't need to use pulse Doppler, but color Doppler and often power Doppler is extremely helpful in delineating the anatomy. Congenital diaphragmatic hernia, relatively uncommon. So most delivery units in the UK are somewhere between 1 and 3,000 and 6,000 deliveries. So in those units, we would expect to see a baby with prenatally diagnosed congenital diaphragmatic hernia, perhaps once every 6 months or so. 1 in 2,500 births. Most of these are left-sided and only a few are right-sided. And it's very rare to have bilateral diaphragmatic hernias. There are variants of diaphragmatic hernia that I'm not going to go into in detail today, such as eventration, that isn't technically a breach of the diaphragm, but a thinning of it. And the thing to note with diaphragmatic hernias, it is often associated with other problems, heart disease. Always think trisomy 18 and 13, not particularly trisomy 21, and rare genetic conditions, of which Pallister-Killian, tetraploidy, and Fryns syndrome are the most common genetic associations. So what about the diagnosis of the condition? Well, a left-sided diaphragmatic hernia, if you get a clear view of the thorax at the four-chamber level, is relatively straightforward. It's not complex. We will often see the fetal stomach right next to the heart, and that's usually what alerts a sonographer or sonologist first to this diagnosis, that you're looking for a four-chamber view of the heart, and you suddenly see this structure next to the heart, which of course is the fetal stomach. Bowel is slightly more difficult to see because it can be similar echogenicity to the lungs, certainly early on. But of course you can see the lumen of the bowel here. So you've got stomach, lumen of the bowel, all next to the heart. So pretty straightforward diagnosis to make. And of course the other thing that you get here is cardiac dextroposition. So left side, the baby's heart is very often shifted over to the right. That's probably one of the commonest things you might miss if you don't actually think when you're scanning at the level of the thorax, which side should the fetal heart be on. So you need to orientate yourself, because of course you may just miss bowel because it looks relatively like lungs. So just be absolutely sure you know which side of the baby is left, and you are checking that the heart is on the left. Right side diaphragmatic hernia. Obviously the liver is immediately below the right hemidiaphragm. Mediastinal shift to the left. You can't see the diaphragm here, but you can see the portal circulation that is pushed up into the chest. So B-mode imaging, important, but color Doppler does tell you you've got an area of intense vascularity, which looks very like a portal circulation. So all aids in the diagnosis. And of course, right-sided diaphragmatic hernia, very commonly associated with liver up into the fetal chest. There are variants of the appearance of diaphragmatic hernia, and sometimes you will see a diaphragmatic hernia with hydrothorax, with pleural effusion. So it's worth bearing in mind that there are forms of diaphragmatic hernia that don't look classic, and sometimes, of course, MRI will help guide you to the diagnosis. So what about the outcome after prenatal diagnosis of diaphragmatic hernia? Well, most hernias are diagnosed antenatally in Europe nowadays. In isolated left diaphragmatic hernia, the survival to discharge, and this is commonly quoted from a live birth and the baby going to the neonatal unit, is in the region of 60%. Many centres, big centres in the UK and elsewhere, quote survival rates of 80 to 90% in isolated congenital diaphragmatic hernia where the baby is live born. And of course that goes down with a left-sided hernia with a lot of bowel and stomach in that side of the hemithorax and compression of the lung. So while most of us would agree that survival depends mostly on the volume of the functional lung, that is not the end of the story. We can measure volumes, and I'll talk a little bit about lung-head ratio, but there's clearly another factor, which is function of the lung. So it is not purely volume, it is function of the lung. So what are the findings associated with outcome? Well, liver displaced into the chest means poor outcome, and lung-head ratio, again, I'm going to talk about in just a moment, but a low lung-head ratio, meaning a very small amount of lung volume, definitely poor for prognosis. Early prenatal diagnosis presumably means the condition is more severe, so you pick it up earlier and the survival is poorer. Also, independently associated is an increased nuchal at 11 to 14 weeks, and of course small lungs, going with the lung-head ratio story. Good outcome, a higher lung-head ratio, classically 1.4, 1.3, undiagnosed antenatally, and normal amniotic fluid as opposed to polyhydramnios in the third trimester of pregnancy. Lung-head ratio, one of the early papers here, showed from over 10 years ago, showed the lung-head ratio of less than 1 was associated with a mortality rate of babies with diaphragmatic hernia of 100%. Lung-head ratio of greater than 1.4 and 100% survival. The lung-head ratio is a little bit like religion. You either believe in it or you don't, and I'm not going to tell you what I believe, but I am going to suggest to you that the whole area is a lot more complex than taking a lung-head ratio cutoff of 1 or 1.4. This is an interesting paper in this area, which was the first systematic attempt at analysing the lung-head ratio in prognosticating, in predicting outcome of the fetus with congenital diaphragmatic hernia. It caused a little bit of excitement when it came out 3 years ago, but it concluded the prognostic use of lung-head ratio in fetal diaphragmatic hernia entered clinical practice prior to publication of robust normal data, and is not supported by current evidence. Application of a structured approach to any new prognostic test could improve its validity. This is very important because, of course, the studies on tracheal balloons are based very largely on the lung-head ratio as a basis of entry to the study, and lung-head ratio changes throughout gestation. What about endoscopic tracheal occlusion? Not shown to be a benefit in an American RCT. Eurofetus trial is ongoing. Complications of PPROM, preterm delivery, neonatal death if the balloon isn't deflated when the baby is born, and possibly tracheomalacia. Having said that, on the other hand, almost certainly does increase lung volume. Whether it actually improves lung function, we don't know. So I would say that most of us would say verdict is awaited on tracheal occlusion. But diaphragmatic hernia used to be considered as one of those conditions that either the baby did not have associated genetic or chromosomal abnormalities, was otherwise okay, and had a repair of the diaphragmatic hernia and was then fine, or the baby had associated abnormalities and or died after surgery. And it used to be considered, certainly in fetal medicine circles, as 1 or 0. Either you're okay and live or not. But of course, it's more complicated than that. And diaphragmatic hernia repair is associated with persistent pulmonary hypertension, chronic lung disease, neurological and neurodevelopmental sequelae, and failure to thrive in certain cases. Okay, let's move on from diaphragmatic hernia to echogenic lungs. Diaphragmatic hernia is one of the commoner thoracic abnormalities. Echogenic lungs, of course, are also in that ballpark, 1 in 1,000, 1 in 2,000 antenatally diagnosed abnormalities. The classic teaching on echogenic lungs is that they split into 2 categories: congenital cystic adenomatoid malformation, otherwise known as CCAM, extralobar pulmonary sequestration. It's a sort of quirk of English that we've tried to make it as complicated as possible. You can, of course, have supra- and infradiagmatic extralobar pulmonary sequestration. Try saying that quickly. So this is ELPS, and that is CCAM. One of the wonderful things that perinatal surgical pathologists and surgeons have done in the last year or two is invent a new classification called CPAM. And the wonderful thing about CPAM is it means that you don't have to spend hours with an ultrasound machine deciding if a baby has CCAM or extralobar pulmonary sequestration or a combination of the two. Because the pathologists say, with some justification, with a lot of justification, that when they see these lungs and bits of lungs, then histologically and morphologically, there isn't an easy cutoff. And some features of CCAM will be seen in bronchopulmonary sequestration and the other way round. So their clear view, surgical pathologists, is that these conditions overlap very significantly, though they may appear different phenotypically, and I'm going to show you pictures of where you could say, yes, that definitely looks like CCAM, that definitely looks like extralobar pulmonary sequestration. It really doesn't make that much difference as long as the lesion isn't very large and causing fetal compromise, because the management of the baby's post-delivery is almost exactly the same. So if we just look at these images, can you tell from this image or that image which is CCAM and which is bronchopulmonary sequestration? Well, you probably could because of the position of this, which is just beneath the diaphragm, and that's the catch here. So, in fact, that is CCAM, and that's bronchopulmonary sequestration. But you can see that both cause, both are space-occupying, both, in this case, microcystic CCAM, are pale and look morphologically quite similar. So let's talk about the different types of CCAM. So I'm not saying that we shouldn't characterize these lesions in terms of their position, whether they appear microcystic or macrocystic, their blood supply, simply that the histology and the pathology will overlap very significantly. And this is lots of little holes, and it is macrocystic CCAM with mediastinal shift, but no hydrops. This image, just here we see behind the heart a homogeneous pale area that is microcystic CCAM with some mediastinal shift, but no pleural effusion. So let's put that together. Fetal echogenic lungs, whether it's CCAM or pulmonary sequestration. The echogenicity, the paleness and enlargement, arises from trapped fluid within the lungs. And as I've said, the pathology and histology overlap to a significant degree. But classically, bronchopulmonary sequestration is an area of lung tissue that is surrounded in its own pleura with a separate blood supply. Usually, the size of the mass, whether it's CCAM or sequestration, decreases with gestation. And it is rare that either of these lesions is associated with hydrops or cardiac failure, but it can happen. The prognosis of both is essentially the same, and the management is the same. So let's just run through some pathological and imaging appearances. So this is microcystic CCAM, the commonest form of CCAM. Okay, and it's a homogeneous, solid-looking area of lung, and that's how it appears on ultrasound. CCAM and BPS tend to only affect one part of the lung. It's incredibly rare to see both lungs affected by CCAM or BPS, and I don't believe I've ever seen that. That doesn't mean it can't happen, it just means that it must be quite rare. But here we see you would be reasonably confident in saying this looks like microcystic CCAM that is replacing one lobe, one lung field there. So it's very clearly delineated anatomically, microcystic and quite pale. So these are really the three categorizations of CCAM. And rather than type 1, type 2, and that should say type 3, we normally say macrocystic, large cysts, small cysts, or microcystic, rather than types 1, 2, and 3. And this, of course, is with macroscopic cysts, and this can cause a bit of difficulty because you can, if you're doing an ultrasound at 20 weeks, see this large area with one fluid-filled cyst, and it can just look like the stomach of diaphragmatic hernia, particularly if it's a patient who is difficult to scan or the baby is spine anterior. So once again, imaging in these situations is just occasionally, not always, helped by MRI scan. But usually what you will see is a more echogenic area around the cyst if it is a large solitary cyst or one or two cysts. So just to summarize CCAM, they can be unilateral but rarely bilateral, macro and microcystic, and can be associated with flattening of the diaphragm if they're very large. Differential diagnosis is with bronchopulmonary sequestration, bronchial obstruction. Generally good prognosis. What do we say to mums when we see them? Well, we typically see these women 20 weeks, 24 weeks, possibly 28, and a final visit at 34, 36 weeks with a pediatric surgeon. And at 34 to 36 weeks, you often won't see the lesion. And that doesn't mean it's gone. It might have done, might have shrunk, but it does not mean it's gone. It simply means that the rest of the lung has become slightly more echogenic, slightly more fluid-filled, and the boundary between the lesion and healthy lung is blurred. So very often at 34 weeks, I can't see something that was absolutely obvious at 20, 24, 28 weeks. And it's for that reason that our pediatric thoracic surgeons, and this is very common, will schedule postnatal scan, not immediately the baby is born, but as long as the baby has no respiratory problems after some weeks or months. So let's move on to the slightly less common extralobar pulmonary sequestration. Nice picture here of a bit of lung enclosed in its own pleura. This can sometimes be associated with an effusion. And what happens? Well, in sequestration, you have a separate blood supply, sometimes from the abdominal or even from the thoracic aorta. And you can image this in a child post-delivery as well. So the classic feature of sequestration is that it has a separate blood supply directly from the aorta, but it can't always be seen easily. So in this situation, we do see that nice separate blood supply going into the sequestration. In CCAM, we see the CCAM surrounding the pulmonary vein, so surrounded by normal vasculature. So the classic differentiating feature of ELPS is the separate blood supply. Okay, what about other positions of sequestration? The feature of sequestration that does not occur in CCAM is that this condition can be infradiaphragmatic. So it's uncommon, but you can see an area of sequestration just beneath the diaphragm. And when this is taken out, it just looks like a little bit of lung surrounded by pleura. So very odd, very unusual, and again a differentiating feature from CCAM. Bronchopulmonary sequestration is lung tissue not connected to the bronchial tree, which is why it becomes very pale, waterlogged, and easy to see at 20 to 24 weeks. Classically, as I've said, a systemic arterial supply from the thoracic or abdominal aorta. It can be intra or extralobar, sub or supra diaphragmatic. The other feature of ELPS, because it's so vascular often, because there's a big blood supply from the aorta going to it, it may be associated with hydrops and a hyperdynamic circulation. Now, if we take a baby diagnosed with echogenic lungs, be it CCAM or ELPS at 22 weeks, it's often very, very obvious, and actually more obvious than this slightly old image here, that there is a big white pale area replacing the lobe. And you might think that on postnatal X-ray you would see it, but you don't. A postnatal X-ray tells you if there's mediastinal shift, tells you if there's displacement of the heart, tells you about the lung fields, but it rarely, if ever, tells you whether there is a lesion or where it is. So our paediatricians do postnatal X-rays to check that the lung fields look relatively normal, to check there isn't gross displacement of the heart. They don't do it to delineate the lesion. And a postnatal chest X-ray is commonly done within 24 hours of delivery. Several different approaches for the pediatric surgical management of these, both these lesions, either open chest surgery or endoscopic removal. Little revision, CPAM, counselling and management substantively the same. Unless hydrops or polyhydramnios develop, it's a good outcome. We recommend delivering in a tertiary centre, not just to drum up business for our own centres, but some of these babies do have neonatal respiratory distress, particularly, of course, if the lesion was a large one, and invariably if there is mediastinal shift plus or minus an effusion. So these babies need access to a unit where there is the full range of ventilation facilities available, and preferably pediatric thoracic surgery. Most of these improve in utero. Surgery or intervention is occasionally necessary. Most babies, because there's a specific discrete area of lung replaced by the lesion, and if that is taken out, the lung grows and replaces the space lost in the baby's lung, most of these babies have good respiratory function. And as you've seen in the previous slide, thoracotomy and increasingly laparoscopic lobectomies are performed with very small scars for these babies. So let's move to some slightly rarer conditions that just merit a mention because you may occasionally see them. As with any part of the body, and classically the abdomen, occasionally you will see single cysts that don't appear to be macrocystic cecam. They are just fluid-filled cysts. And these are conditions that you just keep under review every 4 to 6 weeks on ultrasound, postnatal X-ray, possibly postnatal CT imaging. Depending on the size of the cyst, very unusual for it to be associated with significant respiratory distress. Just going to talk a little bit about laryngeal atresia because this is really the ultimate it's the ultimate end, of course, of causing a blockage to the trachea. Laryngeal atresia causes massive distension of the airways beneath the obstruction and very large lungs. These very large lungs, probably by pressing on the big vessels coming to and from the heart, does often cause hydrops, but often not until the third trimester. So many of these babies are not diagnosed in utero and do extremely badly. Compressed heart here and hydrops from laryngeal atresia and inversion of the diaphragm because, of course, the lungs are being forcibly expanded down into the abdomen. It's one of those conditions where if you did not expect it and a baby is born with laryngeal atresia, they are almost certainly going to die, very unfortunately. Okay, moving on to something a little bit different, fetal hydrothorax, so pleural effusions. Here's a small pleural effusion here, a large bilateral pleural effusion, and a very large, largely unilateral pleural effusion. These are easy diagnoses to make. If you look at a four-chamber view of the heart, you will see an effusion if it's there. What about treatment of effusions? Well, the jury is out. No one is absolutely certain when to intervene, but I think everyone would agree that if there's gross mediastinal shift, if there's a hydrothorax and then you scan at a later point and it looks as if the baby is becoming hydropic, then you would almost certainly want to intervene. And a discussion we frequently have with our paediatricians, and it never seems to be resolved, is do you drain a medium or large-sized pleural effusion immediately before delivery? Our paediatricians put their hands up and say, no, don't. We'll do it after the baby's born. I don't know why they don't want us to do it, but they feel that they can get very rapid drainage of the baby's effusion post-delivery and less risk of us causing traumatic lung damage by inserting a needle antenatally. But if you've got a severe case, then drainage of the effusion either by needling or shunting, so you don't have to shunt, you can put a needle in, can be very, very effective. Aspiration is usually with a smaller needle, 20 or 22 gauge, but of course you may have to repeat aspirate every week or 2 weeks. A shunt, larger trocar, and a shunt may block, but of course the great beauty of a shunt is that only one entry to the thorax is necessary. Most isolated hydrothorax is associated with good outcome, and unless there's a genetic condition such as Noonan's, the likely survival and normality of baby is good. So this is just a picture of antenatal shunt and a postnatal chest drain in a baby. And sometimes these babies are on a neonatal unit for several days, or in extreme cases, a week or 2 or 3 while the lungs expand and the fluid tends to just go on its own. And often we never find out why the effusion was there. It's a very odd thing. The fluid is mostly chylous. There's a small risk of aneuploidy, but of course, with appropriate first trimester screening, you can in most cases screen out high likelihood of trisomy 21, 18, or 13. Just before we finish and I ask you some questions, I want to just show you a case of a large CCAM here. Now, this is rare. Large CCAM that we saw in our unit about November, I think, October or November. Large solitary cyst there that grew and caused polyhydramnios. So we had a very large solitary cyst with a smaller attached cyst, and in this case one of my colleagues decided to drain it, and where's that image? Yes, there we are. You can just about see the shunt there, and this large cyst collapsed and polyhydramnios resolved, hydrops resolved, and the baby was absolutely fine. Now, what about bronchopulmonary sequestration? This is a case that I've just been following up over the last few weeks, in fact. 30 weeks, a small effusion, and there is sequestration as well, not shown very well in this image, but there's bronchopulmonary sequestration and an effusion. Again, you can't see the sequestration very well, but I promise you it is there. And then at 31 weeks, we see a very significant effusion. So we thought, okay, in a week we'll need to pop a needle in and aspirate. But it just shows you don't always have to intervene for things to get better. At 34 weeks, the effusion is completely resolved. And that baby is in fact going to deliver in 10 days' time at 38 weeks. Now, something else happened with that baby, and that is, at the time of the large effusion developing, the baby's middle cerebral artery peak systolic velocity was very high. And the bronchopulmonary sequestration had a very large supply from the aorta. Mercifully, that has changed as the effusion has gone. The vascularity appears less. This baby's grown out of that effusion and sequestration. Although it's still there, it is not proportionately as large in the lung. So rather than having to intervene, wait a bit, and the middle cerebral artery PSV has actually normalized and is completely normal now. So if you want to intervene, you can, but you can wait, and hopefully things may, in certain situations, get better. Right, okay, so now let's go through the correct answers. Please, well, in fact, I'll ask you to vote before going through the correct answers. If you remember, when we first voted on this, the answers were pretty evenly split. And I'll give you about another 10 seconds or so to vote. Still got some undecideds. Okay, shall I press the button? And let's see what the answer is. Okay, so very good. Everyone was listening. That's excellent. So, of course, missed antenatal diagnosis is associated with a good outcome. Pleural effusion is very uncommon. Let's move on to the next question. Extralobar pulmonary sequestration, high output cardiac failure, more common than in CCAM, more likely associated with aneuploidy than CCAM, frequently treated by aspiration or shunting, easily imaged with postnatal X-ray. So please vote. Voting's a bit slower on this one. I think most of you got it right in the first place, so we'll see. Okay, so let's see what the outcome is. All right, okay. So bronchopulmonary sequestration, do you remember those images I just showed you of the pleural effusion and the middle cerebral artery peak systolic velocity is more vascular than CCAM, more likely to be associated with high output cardiac failure. The association of aneuploidy is very unlikely with both conditions. Frequently treated with aspiration and shunting, no, it's quite rare. We might aspirate or shunt once every year or two with CCAM. Very uncommon, and isn't easily imaged with X-ray, easily imaged with CT, but not with X-ray. Good, thank you. I think we're there. Yep. Does anyone have any questions on that lecture, on what I've said? All reasonably clear? No questions? Good. I'll move on.